I'm not sure if this topic falls within the category of promoting useful knowledge, but perhaps you'll have some opinions about that when I'm finished. This cover from Nature magazine in 1991 depicts Lincoln towering over his Union generals, convincingly fueling the speculation that Lincoln had Marfan syndrome. As was quoted in Time magazine in 1978 by Dr. Schwartz, a California physician you'll hear about later, quote, "Had John Wilkes Booth not fired that fatal shot on April 14, 1865, Lincoln would have died within a year of complications from Marfan syndrome, for which there still is no cure." We have two pictures of Lincoln here. The one on the left was taken around March 4th, 1861, at the time of his first inauguration. And the one on the right was taken February 5th, 1865, just prior to his second inauguration. And in order to frame this a bit, remember that Appomattox occurred on April the 9th, 1865. Lincoln was assassinated April 14th, 1865, when he was just 56 years of age. We're used to seeing our presidents age during the course of their presidencies, and you can certainly see that in Lincoln here. In 1865, there's much documentation of recurring profound exhaustion, both leading up to and after his inauguration, which contributed to the speculation, in fact, that he was close to death before his assassination. In fact, the day after this picture was taken on February the 5th, Lincoln fainted publicly. I would call attention to his hands, and you can see how large his hands are in this picture, and we'll get back to that subject matter a little bit later. So what do we know about Lincoln's health? We know facts and we know speculation. The yellow here is purely speculative. Lincoln had a healthy childhood. He had a near drowning incident as a young boy when he fell into a creek and a friend pulled him out. He was kicked in the head by a horse at the age of 9, suffering a period of unconsciousness. Probably he had a concussion. But he was an active young boy. He was active in wrestling, physical sports of the day, and everybody knows Lincoln liked to chop wood. His height was pretty accurately put at 6 foot 4 inches. He was well-muscled but thin. In 1859, before his first presidency, he self-reported his weight at 180 pounds. He likely suffered 3 bouts of malaria, as demonstrated here, and he was known to suffer from depression and melancholy. In 1835, he had a serious bout of depression, probably related to the death of a close friend, Anne Rutledge. And in 1841, he had another bout of depression, possibly related to a broken engagement to Mary Todd, but maybe as much related to the departure of his closest friend, Joshua Speed, who returned to Kentucky. One must submit that Lincoln had plenty to be depressed about. He presided over the United States when hundreds of thousands of Americans were killed in battle. He lost 2 children. His first son, Eddie, died either of diphtheria or consumption at the age of 4 in 1850, and he lost his second son, Willie, of probably typhoid fever in 1862 during his first presidency at age 11. It was speculated that Lincoln had syphilis, and this came from some writings of his former law partner, William Herndon, but there is certainly no evidence to support this. He probably suffered smallpox in 1863, immediately after he delivered the Gettysburg Address. But it is in fact Marfan syndrome that is the most tenacious disorder most associated with Lincoln. Dr. Victor McCusick of Johns Hopkins University School of Medicine, who's considered the father of modern genetics, was quoted in 1991 at putting the chances of Lincoln having Marfan syndrome at 50-50. There is a condition called multiple endocrine neoplasia type 2B. Dr. Sotos proposed that Lincoln might have had this disorder, But in fact, untreated MEN patients virtually all die before the age of 30. He was known to suffer from constipation and headaches. He took pills which were referred to as blue mass pills, which were composed of a high calomel content, also high in mercury. Again, no real evidence that he suffered from mercury poisoning. He did suffer from nervous and physical exhaustion, certainly in the late 1864, going into 1865. He actually resorted to holding cabinet meetings in his bedroom because he was too weak to get out of bed. But on April 8th, again a few days before his assassination, he rallied and made a marathon visit to multiple hospitals, reportedly shaking hands with up to 5,000 patients in one day, after which his doctors were worried he had become lame, and he immediately went outside and started chopping wood, and reportedly actually held an axe out to the side with one hand without quivering, a feat that very few people could have done. So let's switch gears a little bit and talk about Marfan syndrome. Marfan syndrome is a connective tissue disorder. It was first described by a French pediatrician in Paris in 1896, who treated a young girl with a congenital disorder of all four limbs, lumbar kyphoscoliosis, plexus carinatum, who died at the age of 16. Marfan described the clinical manifestations including cardiovascular, ocular, and skeletal systems. Aortic pathology was first defined in Marfan syndrome in 1943, a year after the French Marfan died. It's an autosomal dominant Mendelian trait, which means that offspring have about a 50% chance of getting the disorder. But we now know that about 25% of cases actually result from a de novo mutation. The incidence is about 2 to 3% out of 2 to 3 per 10,000 individuals. There is no gender or race predisposition. And there's an increased incidence in athletes, particularly athletes who have a tall stature and long bone overgrowth, including basketball and volleyball players. The ocular manifestations are in fact nearsightedness and dislocated or sublux lenses. In fact, Marfan patients have very poor eyesight. In terms of the skeletal clinical manifestations, they're demonstrated here. The long, large hands and feet, the skinny fingers, which have been described as arachnodactyly, the sternal abnormalities, the spinal abnormalities, including scoliosis and kyphoscoliosis, the laxity of the joints, and a particular phenomenon where when the arms are outstretched to the side, they are actually longer than the height of the individual. Prior to thresholds for aortic root replacement, cardiovascular catastrophe and death in the form of aortic rupture, aortic dissection, valvular disease, and congestive heart failure occurred in over 90% of the patients before the age of 40. It has been the refinement of aortic root surgery that changed the lifespan of patients with Marfan syndrome. Yet in the 1970s, as far as surgery had come, longevity was only 2/3 of those unaffected individuals. And we'll talk a little bit about what it is today. In terms of the pathogenesis, McCusick first described the structural defect in the elastin fiber, that is decreased content and fragmentation, in 1955. In 1986, Sakai described the fibrillin-1 extracellular glycoprotein, which was in fact present in all tissues with phenotypic manifestations of Marfan syndrome. And the Marfan locus mutation was in fact mapped to chromosome 15 in 1990. In terms of the abnormal cellular pathways and the phenotypic consequences that result from this genetic defect, if you start with abnormal fibrillin-1, this results in cells adopting matrix-degrading enzymes through an upregulation process of metalloproteinase enzymes. This results in disruption of aortic wall hemostasis, weakening of the elastic fibers, inflammation and calcification. And if you look pathologically at these aortic specimens when we take them out, you see cystic medial necrosis in the medial wall of the aorta. Fibrillin actually has strong homology to transforming growth factor, which may in fact be responsible for sort of the more unusual phenotypic expressions through a dysregulated cytokine activity. In 2010, the Ghent criteria were revised, and these are, in fact, the cardinal manifestation of Marfan syndrome today: aortic root aneurysm, ectopia lentix, or a dislocated subluxed ocular lens, and we now have the ability to do genetic testing. In fact, the dramatic skeletal findings are less predictive of having the disorder. Here is an example of an aortic root aneurysm. I guess that's not working too well. With a dissection flap in the descending aorta where you see the arrows there. If you focus to the left, this is a depiction of the aorta from the aortic root right above the aortic valve up into the aortic arch and down the descending and abdominal aorta. We refer to the descending thoracic aorta and abdominal aorta as the thoraco-abdominal aorta into the iliac arteries. And here's an example of a normal heart with ascending aorta to the left, and you can see the heart with an enlarged aorta to the right. This is what it looks like graphically. And cardiac surgeons, I'm not a cardiac surgeon, I'm a vascular surgeon, repair these with an ascending aortic tube graft, sometimes replacing the aortic valve, but sometimes today doing valve-sparing therapy, which is in fact very successful. I get involved in these patients when they in fact have extension of their disease into the arch, descending abdominal aorta, and iliac arteries. Progressive aortic root dilatation has another effect. It results in incompetency of the aortic valve or aortic valvular regurgitation. This results in an exaggerated pulse pressure. Pulse pressure is the difference between systolic blood pressure and diastolic blood pressure. And with aortic regurgitation, that pulse pressure becomes widened. And it results in some clinical findings that have been named by a number of physicians. My name's not there. But it includes things like a pulsatile liver, a pulsatile uvula, pulsatile spleen, and what has been referred to in this picture as Quincke's sign. Quincke's sign is exaggerated pulsation of the capillary nail beds. This is not Quincke's sign, but it is often pointed to as suggesting that Lincoln had Marfan syndrome. And if you notice, his left foot, which is closest to the camera, is out of focus. And people said it was out of focus because he couldn't keep that leg still. His pulse pressure was so wide that he couldn't sit still for the picture. This is the cover of Sports Illustrated magazine from February of 1986, and I'll call your attention to the top special report, the malady that struck down Flo Hyman. Flo Hyman was the best American volleyball player we've ever had. She led the U.S. women's volleyball team to win a silver medal in the Olympics, and in the winter of 1986, she was playing for a very talented Japanese team in Japan, and at the age of 31, on January 24th, she suddenly died during a game in Japan. Her parents were called in California. They were told she had a heart attack. When they got her body back to Culver City, California, they called for their own independent autopsy, and they found that, in fact, she had a ruptured aorta and had Marfan syndrome. In this same article, Reed Piritz, to the right, who was a young geneticist who studied under McCusick, was interviewed at Johns Hopkins. Reed was treating up to 400 patients a year at that time with Marfan syndrome. And Reed was quoted as saying, "Often the first person to make the diagnosis of Marfan syndrome is the coroner." To the left of Reed in this picture is Vori Billups. Billups was recruited to play basketball at that powerhouse, St. Bonaventure, in 1984 on a scholarship, already aware that he had Marfan syndrome. His doctors, including Reed Pirrett, subsequently decided it was too risky for him to play Division I basketball, but he kept his scholarship. He graduated college. He now lives in Georgia, working as an admission director for a Southern university. Let's talk a little about current aortic surgery and Marfan syndrome. And beyond beta blocker therapy, which many of you are familiar with, or angiotensin II receptor blocker therapy, like losartan, Marfan syndrome is a surgical disease. And conventional open operations, big operations, are still mandated. If you were here for my talk a couple years ago, endovascular approaches that rely on persistent radial forces for fixation are contraindicated in Marfan patients. Why? Because they have weak connective tissue. And when you put a device in that relies on radial expansion, it ends up tearing the aorta. So what's required are traditional surgical operations. We know that when you operate in the thoracoabdominal aorta, you risk paraplegia, so we tend to stage these operations over a period of time to allow the spinal cord to collateralize. These patients need lifelong surveillance with yearly imaging, and unfortunately, reoperation is common as the aorta, in fact, continues to elongate throughout the lifespan of these patients. Yet a normal lifespan is actually achievable. I'm sorry for this picture after lunch, but it depicts the magnitude of the operations that we do. This is a tube Dacron graft in the abdominal aorta. The branches coming off the graft are all sewn into branches that we can't do without: the visceral vessels, the renal arteries, and to the right, the iliac arteries supplying the legs. Well, this is Vori Billups today. He's 52 years of age. He had his aortic root and valve replaced when he was 25 years old in 1992. He underwent repair of abdominal aortic aneurysms and bilateral common iliac artery aneurysms in 2003. And yet 15 years later, that repair degenerated with the development of new aneurysms, and he came up to Penn this past fall, and I redid his aorta and iliac. He should live a normal lifespan. This is not Abraham Lincoln and Ron Fairman, but this is William Goldman, who's another one of my Marfan's patients, who actually at this point in time, 57 years of age, has had his entire aorta replaced at least more than once. But he does fit that distinct physique of Marfan's patients. He's tall and lanky, he has stooping shoulders. Notice his long arms, he wears glasses. So let's look at the evidence. Lincoln had Marfan syndrome. This was first published by a physician in Kentucky, an internist named Dr. Gordon, who wrote about Lincoln's physical appearance. He proposed it came from the maternal side of Lincoln's family. He referred to Lincoln's high intelligence, and Marfan's patients are very intelligent. And he described what he thought were the ocular symptoms. This was supported in 1964 by multiple publications from a California physician named Dr. Schwartz. And Dr. Schwartz actually had treated a young patient with Marfan syndrome who was interestingly descended from a family named Lincoln. Schwartz methodically analyzed Lincoln's records. He did detailed analysis of what he thought were Lincoln's skeletal indices. He reported his eye findings, and he actually created an 11-generation hypothetical genetic line proposing that it came from his father's side of the family. He suggested that Lincoln had aortic insufficiency and in fact was in the early stages of heart failure during his presidency. Lincoln often said, quote, "My feet and hands are always cold," certainly consistent with a widened pulse pressure. McCusick himself, in his textbook, Hereditable Disorders of Connective Tissue, repeatedly made this Lincoln link to Marfan syndrome. And Moses and Cross, who published a book in 1980 on the health of our presidents, said that Lincoln's illness would have proven fatal before the middle of his second term. Well, what's the argument that Lincoln did not have Marfan syndrome? Well, finally, there was some opposition in 1981 by Dr. Latimer. Latimer was the retired chair of urology at Columbia Hospital in New York, and he felt that Lincoln didn't have arachnodactyly. He didn't have spider-like fingers. In fact, if you remember that picture I showed you, his hands were huge, but they were muscular. And in fact, when he was laying on his deathbed, his torso was noted by his physicians to be unusually muscular, not cachectic. He did not have lax or unstable joints. He couldn't have physically done the things that he did if he had. And there was certainly no evidence that he ever had pectus or scoliosis. His partner, again, law partner Herndon, said he was a champion backwoods wrestler, a very powerful man. Lincoln, in fact, was not nearsighted. He was farsighted. He had pretty good eyesight. And in fact, when he was assassinated, in his vest pocket were 2 pairs of very mild reading glasses. He actually was quite a good marksman and a sharpshooter, so he did not likely have ectopia lentis. So although Lincoln appeared to have a Marfanoid skeletal appearance, he lacked the cardinal manifestations of Marfan syndrome. And I would bring you back to the Ghent criteria of 2010. There was an interest in doing genetic testing on Lincoln's bloody clothing, but this was prevented by a historical society in the late 90s. I would say that were he not assassinated on April 14th, he would have lived for many more years and been productive. So is this voyeurism? Is this medical voyeurism as proposed by the ethicist Arthur Caplan? Or in fact, is this an historically important question which is relevant to the self-esteem of patients who have Marfan syndrome? Marfan syndrome remains today a surgical disease, a complex surgical disease. These patients may live a normal lifespan with early life-saving root replacement therapy, and as I've demonstrated, usually this occurs in their early 20s or 30s. And although current imaging recommendations only focus on the aortic root with echocardiography, if I had a child with Marfan syndrome, they would be getting total aortic imaging throughout their lifetime. So again, thank you for your attention. I don't know if this is useful knowledge, but thanks for listening to me.
Well, thank you. That was fascinating. We'll take questions. I just want to mention Dr. McCusick and also Chief Justice McCusick, identical twin brothers who were stalwarts of this society. Should not go without mentioning in this. I'm going to ask the first layperson's question, which is, you mentioned it almost as a throwaway line that Marfan's patients tend to be very intelligent. So what would be the mechanism for that?
I don't know. You know,
okay.
I think there's almost a pejorative assumption that patients that look funny are not intelligent. But I think that's sort of the point. Many of my Marfan's patients are brilliant individuals who have very successful careers, in spite of their other disabilities.
Okay, well, I know we have some very distinguished geneticists in this room, so maybe somebody has a theory that could advance it. But, okay, Erwin.
Hi, Erwin Shapiro. Fascinating talk. May not be useful knowledge, but was very interesting. I have a crazy question. It's now 150 years later.
Mike, hold the mic up.
After Lincoln's death. Has there been any development which would enable one to say from his remains whether he had Marfan syndrome? In other words,
sure.
If he would dug up his remains, could one, by a suitable autopsy type approach, determine definitively whether or not he had Marfan syndrome?
So this was a very hot topic in the 90s. Lincoln, as you know, is buried in Springfield, and there were multiple attempts to rob his grave. And so his son, Robert Todd Lincoln, made sure that that was never going to happen, and they poured tons and tons of concrete over his tomb. And so that's not going to happen, that they're going to exhume his body. Lincoln has no living relatives that we know of. There are samples, as you might guess. There are samples of his skull. There are hair samples. There's blood on the clothing that he was wearing. There's blood on Mary Todd Lincoln's white cape that she was wearing. And you could do DNA analysis with the chances of getting a positive result. Doing those DNA analyses would result in destruction of those artifacts. And there's been a feeling that no one's willing to give those artifacts forward for them to have DNA testing. So it hasn't been done. It could be done.
Bill Brinkman from Philadelphia, wondering about, you mentioned gene modification at the beginning, but you never said much about that. Is it possible that it will create a cure?
Is it possible that there'll be a cure?
Might become a cure?
I don't think it's likely to happen in the foreseeable future. Obviously, I'm not a gene specialist, but I'm not aware of any projects undergoing right now where there's any ability to reverse the gene mutation, the fibrillin 1 mutation.
Linda in the balcony.
Balcony.
Yes, Larry Einhorn, Indiana University. I thought it was an excellent talk. I thought it was useful too. So one of the other things against his having Marfan's, even though it wasn't discovered until 30 years after his death, wouldn't his team of physicians have noticed some ocular changes, heard a heart murmur, or found some physical findings? I don't mean to impugn their physical examination skills, but wouldn't that have been noticed?
So Lincoln's personal physician wrote extensively about his eye findings, also discounting the possibility that he was myopic or that he had poor eyesight. Lincoln had funny-looking eyes ever since he was kicked in the head by a horse, apparently. And that probably resulted in a drooping right eyelid. His personal physician actually subspecialized in ophthalmology, believe it or not, back in that period of time. So he had a lot of interest in his ocular findings and actually wrote a lot about it, also not supporting the idea that he had Marfan.
Hi, Steve Lippard. This is quite interesting. Just a point of clarity. I thought at the beginning you said that if Lincoln hadn't been assassinated, he would have died shortly thereafter of Marfan's, whereas at the end, you predicted he would have lived a very long life. How do you resolve that?
So the initial statement that I made was a quote in Time magazine by Dr. Schwartz in 1978. So I can't take ownership of that statement, but I will take ownership of the final statement.
Fair enough.
Okay.
Okay. We have to stop. So, thank you.